Καλησπέρα σε όλους. Χαιρόμαστε που είσαστε όλοι εδώ μαζί μας για το συνέδριο διαδερμικών βαλβίδων του Νοσοκομείου Υγεία. Είναι ιδιαίτερη χαρά που έχουμε σήμερα φίλους καρδιολόγους και καρδιοχειρουργούς από την Ελλάδα και από το εξωτερικό μαζί μας για να συζητήσουμε όλες τις τελευταίες εξελίξεις στον χώρο των βαλβιδοπαθειών. Σήμερα έχω τη χαρά και τη τιμή να έχω μαζί μου τον καθηγητή, τον κύριο Mack, ο οποίος έχει κάνει πολλές από τις καινοτομίες που έχουμε συζητήσει σήμερα. Dr. Mack, it's a real honor and a pleasure and a privilege to have you with us today. For our audience, we want to give them a summary of what you consider to be the latest developments in the field of heart valve disease, both transcatheter as well as surgical. What do you think are the biggest innovations that have happened in the past 2-3 years?
Well, first of all, Greg, it's an honor for me to be here in Athens. It's an absolute pleasure. I think a couple things. As you well know, all four valves within the heart can now be approached by a transcatheter approach. But I think we have to modulate our expectations. I think, like in life, lightning only strikes once. I think lightning has struck in transcatheter valves, and that's TAVI. I think the expectations for mitral and now tricuspid have been the same, and I don't think they're going to be the same. Mitral has not been nearly as rapidly adopted as aortic, and as a matter of fact, they were both introduced at the same time in the United States, and there's 7 times more TAVI valves done than TEER procedures done, despite a higher prevalence of mitral valve disease than aortic valve disease. I also think that we've reached a steady state regarding the proportion of TAVI versus surgery. Okay. I think we're at about 75 to 80% of aortic stenosis is treated by TAVI. I don't think that's going to change much in the future. I just think it's going to stay the same ratio as CABG to PCI.
I see.
Now, 2 tricuspid transcatheter procedures have just been approved in the United States. One is replacement and one is repair. The repair was approved on the basis of patient-reported outcomes only.
Right.
I don't think we know how much of an impact transcatheter therapy is going to make in tricuspid disease. Whether fixing the tricuspid regurgitation truly changes the disease or it's just a marker of end-stage right ventricular dysfunction.
Right. For our friends out there, for our colleagues, our cardiac surgical colleagues who do not have transcatheter skills and are looking at a somewhat shrinking portion of the pie in terms of aortic valve disease, what cases, to simplify my question, what cases do you think are going to continue to be in the surgeon's hands without debate for patients with aortic valve disease?
So I think a couple. I think there's a number of opportunities for surgical aortic valve replacement to still play the major role. I think the first is in younger patients. One is the Ross procedure, which is undergoing a renewed interest. There's only 700 a year done in the United States, but the number is increasing again, and I think as we get more and more expert surgeons doing it, that's going to continue to increase. Secondly, we can't forget about mechanical valves. Multiple series show that life expectancy at 15 years is longer with mechanical than tissue, and nobody wants mechanical valves because they have to take anticoagulation, but it really is an option that we shouldn't forget. Thirdly, aortic valve repair, especially with bicuspid valves. And then concomitant disease. Right. So if you have concomitant coronary disease, make the choice based upon whether if the patient didn't have aortic stenosis, you choose CABG or PCI. So 3-vessel disease, left main disease, high syntax score, that patient should have an AVR plus CABG.
Yeah,
and low if it's PCI, then a staged PCI TAVR would be the right
Fantastic.
answer.
I think you've highlighted all the cases where I think it's clear that surgery has the advantage now. I think that we've been discussing this all day with our cardiology and cardiac surgery colleagues in these sessions. So thank you so much for being here with us to contribute to the conference.
My pleasure, Greg.
Appreciate it.